مرحبا بكم. So, I am Dr. Ghazi from Tunis, Tunisia. As you know, Tunisia is a francophone country, so it's difficult for us to speak in English. We try to speak English to make this presentation in English, so we begin. The first part of the presentation is like an introduction for Retraction Pocket, and the second part is discussion about some clinical cases. These cases are not again treated, so we will discuss the indication in front of this kind of retraction pockets. As you know, retraction pocket is a retracted weak part of tympanic membrane having lost its lamina propria and collapsed into the middle ear cavity. It may concerns pars tensa or pars flaccida. It's a pre-cholesteatomatous state. There are some nosological consideration. Middle ear atelectasis is like retraction pocket, but it concerns all the eardrum. Adhesive otitis media, it's the same thing, but in this case, there is no more air in the middle ear, and fibroadhesive otitis media is the case when the middle ear is filled with fibrous tissue. Classification of retraction pocket may be useful in many cases, but it's more important to well describe the aspect of the retraction pocket under microscope. The simple classification of Charachon is the one most used in the world. It's simple. He classifies retraction pocket in 3 stages. Stage 1, mobile retraction pocket fully visible under microscope. Stage 2, fixed and controllable retraction pocket fully visible under microscope. And stage 3, fixed and uncontrollable deepest part of retraction pocket invisible under microscope. Now, some authors introduce the exam with endoscope to examine the bottom of the retraction pocket. The management of retraction pocket has no consensus. Several approaches in treated these pathologies. We can watch and wait to see the evolution. We can use conservative approach like medical treatment, ventilation tubes, and then there are some surgical solutions. The indications also are not clear. For stage 1, perhaps it's clear for all the authors, we must use a conservative option. For stage 2 and 3, there is no consensus. It depends on severity of the retraction pocket. Severity means what we see under microscope, and especially the symptoms of the patient. So, as we said, the retraction pocket is a pre-cholesteatomatous state. In some case, the line between severe retraction pocket and cholesteatoma is not clear. And the severity of retraction pocket, the signs of severity are otorrhea, which means instability of the retraction pocket, fixation of the retraction pocket to the ossicles, to the promontory. The deepest part of the retraction pocket is not controllable. The widening of the bone frame, which called atychotomy, presence of squamous coming from the retraction pocket to the external auditory canal. In French, we call it coulée de lave. In English, I think it's lava flow. I don't know if the term is exact. And severe hearing loss. CT scan. In major of cases, CT scan is not necessary in front of a retraction pocket. We can use it if we have a severe hearing loss, or if we are going to operate to see the state of the ossicles and to see if there is extension in posterior cavities. Now we are going to present some clinical cases and try to discuss what must we do. تفضل.
Thank you, Dr. Besbes. Alors, we start with the first clinical case. It's about a 5-year-old child who presents bilateral deafness. In the history, we find or we note tonsillectomy and adenoidectomy. And this is the otoscopic aspect. In the left ear, we have a global or total retraction of the tympanic membrane, which is fixed to the promontory, to the joint, to the enchidostapedial joint. The retraction is clean. There is erosion of the frame bone too, and there is an aspect of otitis effusion in retrotympanic. In the right ear, the tympanic is congested, and audiometry shows a conductive hearing loss bilateral. What you propose? It's an atelectatic ear in the left, and an aspect of effusion otitis media in both sides, in both ears. Sorry. We propose a medical treatment and a ventilation tube for the two ears. The left ear is surgery can be proposed later for the left ear. Second case, clinical case, a 27-year patient who presents in his history ear infections in childhood, and he presents a deafness in the left ear too. Otoscopic aspect, he presents a retraction, large retraction posterior, a large posterior retraction, who is clean, fixed to the enchidostapedial articulation joint. Donc we can see all the compartment of the pocket, and audiometry shows a conductive hearing loss, an important conductive hearing loss. What you propose? Surgery. Because essentially for the conductive hearing loss, considered signs of severity for the retraction pocket. Alors, we propose tympanoplasty and ossiculoplasty. with cartilage. We can put a piece of cartilage directly on the head of the step under the ankles to perfect hearing result. Case number 3, a child who presents deafness, right deafness and episodic otorrhea, and the otoscopy shows an epitympanic retraction with erosion of epitympanic bone, large posterior retraction pocket with erosion of osticles. There is no ankles, donc the retraction pocket is fixed directly to the head of the ankles. It's fixed to the nerve facial, and this pocket is uncontrollable, with resulting hearing loss, conductive hearing loss 40 decibel. We propose surgery, tympanoplasty for this ear, and carefully dissection of the retraction pocket, ossiculoplasty with prosthesis or cartilage, and total reconstruction of the tympanic membrane and of the bone eroded. Case number 4. Here we see the aspect of the ear, 37 years, with deafness, pain, and episodic otorrhea. Audiometry shows a mixed hearing loss for the right ear. What you propose? An important sign here in otoscopy is the lava flow. Donc it signs the evolution for cholesteatoma. Donc we propose surgery and dissection of the retraction pocket and the total reconstruction for the tympanic membrane and the canal bone, the defect in the canal bone.
Thank you. Some other case, it's a woman, 47 years old, who presents in the right ear otalgia and hearing discomfort. Otoscopic shows this aspect in the right ear and this aspect in the left ear. And audiogram shows a mild hearing loss, 20 dB of conductive hearing loss. What we can propose for the right ear, it's a non-controllable epitympanic retraction pocket with a wide atychotomy with epidermal scales. It's a real cholesteatoma. So in this case, we propose tympanoplasty with mastoidectomy and anterior tympanotomy and the reconstruction of the eardrum and the atychotomy by cartilage. The left ear, it's a atelectasic tympanic membrane with atycal epitympanic retraction pocket, which is clean and controllable, no significant hearing loss, as we said, only 20 dB hearing loss. So in this case, we prefer watchful waiting and not to operate. Even ventilation tube with this state of hearing is not recommended for us. Case 6, it's a particular case. It's a man, 40 years old. His right ear was operated for cholesteatoma. he has a canal wall-up tympanoplasty. This left ear, he has no complaint, but it's a discovery of otoscopic exam. And in the audiogram, the right ear, which was operated, he has conductive hearing loss at 50 dB, and in the left ear, this ear, it's 30 dB. So it's a discovery of exam, no complaint from the patient. It's a self-cleaning retraction of the tympanic membrane. There is no squamous, no signs in this stage of cholesteatoma, and especially it's a precious ear. So in the left ear is the better hearing ear. So there is some risks operating this ear. So we choose watchful and waiting, only because the problem of it's one single hearing ear. The seventh case, it's a woman who has 48 years old, hearing loss in the right ear, with a mixed hearing loss, 40 dB, and left ear is normal. We can discuss this case. As we see, there is an atypical retraction pocket, not entirely controllable, but clean and dry in this case. And probably there is a fusion in the middle ear. And the hearing loss is 40 dB. So there is a problem of hearing loss. We can discuss in this case, or we can have a conservative approach. We mean we can treat medically and put a ventilation tube in this ear and see what happens. In some cases, the retraction pocket can move and replace in a good place, and in other case it doesn't move. And if there is no improving of the hearing, we can propose surgery. The last clinical case, it's a woman who has 53 years. She presents hearing loss in the right ear. She doesn't report notion of otorrhea. In the audiogram, we find hearing loss, a mixed hearing loss at 45 dB in this ear, and the other ear is normal. It's a case, so wide atychotomy, which permits to control all the retraction pocket, atypical invagination. It adheres to the ossicles. The ear is dry, and she has conductive hearing loss. We can propose surgery in this case. We can make a tympanoplasty with a reconstruction, but we must know that it's not an easy surgery to remove all the epiderm that adheres to the ossicle and to the bone of the attic. We must be careful not to let in place some fragment of epiderm which becomes a real cholesteatoma. It's not an easy surgery. It's the last case. Now, the attitude, as we said, we think in not our point of view, in stage 1, there is no surgery. In stage 3, probably we need surgery, and in stage 2, controllable and fixed retraction pocket, it depends on the aspect in examination under microscope, and especially the symptoms and the complaints of the patient. If there is otorrhea, if there is hearing loss, significant hearing loss, if there is some signs that can make us careful about development of cholesteatoma, we can go to surgery. I show you, but it's an old video, excuse me, but it can just demonstrate how we can this is retraction.
Doctor, your time is up.
We began at 11 and okay, thank you. So we took 15 minutes. So it's a posterior superior retraction pocket which is fixed to the stapes. The long process of the anchus is absent, it's eroded. So what we do, it's excision of the retraction pocket. In this case, the lesion is only posterior and superior. So we didn't need to décoller or the tympanic membrane. We let the membrane fixed to the malleus, and then we put a fragment of cartilage on the scotum to reconstruct the atychotomy, and a fragment of chondroperichondrial cartilage to reinforce the posterior and superior part of the eardrum. And sometimes, if the cartilage doesn't touch the stapes, we can put another fragment of cartilage. But in this case, it's in contact with the stapes. Thank you for your attention.